So our next session is going to be on pulmonary embolism, which I think should generate a lot of discussion. I like to think of PE a lot like syphilis in that it can present in any way possible. So let me ask Dr. Wong and Dr. Rahaghi to come on up and start the session.
Okay, so it is my pleasure to introduce our first speaker who is going to wake everyone up. He is one of our leaders in the vascular medicine program and has been leading a number of clinical initiatives and trials ranging from role of anticoagulation to different devices to treat acute PE. I'd like to introduce Dr. Gregory Piazza.
Thanks so much, Nick and Aaron and the rest of the planning committee. It's a pleasure to be here. This is, one of my favorite conferences. I'm amongst friends, so I can say this. The RV is much more interesting than the left ventricle. Jane, don't bring that back to the home base, though. And I'm going to be, I guess it is a good wake-up topic, clot in transit. It's probably pretty scary when you see it. And that's what we're going to dive into. There's a lot of sort of areas where we could use more data. Here are my disclosures. And what I'd like to do over the next few minutes is go through some epidemiology and risk factors for clot in transit. We're going to look a little bit at the overall therapeutic approach to clot in transit. I'll tell you that there aren't strict guidelines for this. And then we'll dive into some catheter-based therapies for right heart thrombi, a very rapidly growing area in intervention. So this is what we're talking about today. It's a nice example of a clot in transit. This is an apical four-chamber view. And if I can get you can see this here. Mobile echo density in the right atrium starting to want to make its way across the tricuspid annulus. When we see this usually generates a myriad of phone calls. And we'll talk a little bit more about what we're supposed to do about this and why patients get this. The epidemiology is not really well worked out, but this is a nice way of looking at it. This comes out of a PE response team analysis, looking at sort of the different PE response team activations and how many of these actually involved a clot in transit. So if we look at about 1,100 PERT activations, about 850 had echocardiograms, about almost 800 of those had good echocardiograms, and then about 7.2% of the cases had clot in transit. So when you look, you will find this. It's not frequent, but it's not infrequent either. And like I said, it generates a lot of interest when you actually see an echo with one of these, and so it's worth knowing what to do. Now, if you look at the European Society of Cardiology guidelines and other recommendations for how you risk stratify patients with PE, guess what? You won't find a lot about clot in transit. So these are the European Society of Cardiology guidelines. They divide patients up into low-risk PE, intermediate low-risk PE, intermediate high-risk PE, and high-risk PE. Where's clot in transit? Well, because clot in transit doesn't show up on these types of risk stratification algorithms, it can be confusing on how you should treat these patients. And when you look at the ESC 2019 guidelines on how to treat patients, again, notably absent is clot in transit or right heart thrombi with concomitant PE. A lot of times we'll consider them to either be somewhere in the intermediate high risk to high risk, but there's very little data for that. And so it really leaves us with a huge data void on how we should be approaching these patients. So to do that, it's very interesting. The widespread adoption of multidisciplinary PE response teams has sort of coincidentally helped us understand how we should be looking at clot in transit, because these large registries that are generated out of PE response teams gives us the ability to start to look at what people do in the real world with clot in transit. So looking here, these are, again, lessons from a PE response team experience. What we can see is there are some presentations that are associated with clot in transit. Patients who have underlying heart failure seem to have almost threefold increase in the odds of presenting with clot in transit. Central venous catheters, I think this one we can all kind of realize, about 2.5 increase in the odds of presenting with clot in transit. And then if you're hypotensive, probably just a marker of how severely sick you are, potentially with a pulmonary embolism, a twofold increase odds in presenting with clot in transit. We can see on this side that catheter-based intervention, although it's becoming more popular, doesn't seem to be more common in patients with clot in transit and PE compared with PE alone, but open surgical embolectomy, probably because that's what we've traditionally used for clot in transit, much more common for that manifestation, and then patients needing ECMO. Also much more common to have death by 7 days and need endotracheal intubation. I think it's widely understood that if you see clot in transit, you're looking at a patient that has higher risk in the setting of pulmonary embolism, but it's nice to actually see that quantified here. Looking at clinical outcomes, things that you can expect to find in your clot in transit patients. Severe hypoxemia tends to be seen with high frequency in patients with clot in transit. Likewise, echocardiographic markers of right ventricular dysfunction, very common. We're talking 90s to 70% of the patients who present with clot in transit will come in with dilated right ventricles, paradoxical septal motion, signs of right ventricular pressure overload, systemic pulmonary arterial pressures, and it's important to note that on TEE you might see a patent foramen ovale, and patent foramen ovale by itself is an adverse predictor of outcomes with pulmonary embolism. Typically, when we see what's done for these patients, open surgical embolectomy is what we've relied upon, but we're going to spend some time talking about catheter-based intervention, which is becoming more and more popular. And then it's certainly portends a poor prognosis for our patients with clot in transit who come in with arrest or with severe hypoxemia. And here we see a nice example of what gets removed in embolectomy here, large clot in transit. So a proposed algorithm, certainly not based on any wealth of randomized controlled trials we can see here. So right heart thrombus in the setting of acute PE really should best be managed with a multidisciplinary PE response team approach. There's too many questions and too few guidelines in randomized controlled trials for it to be managed really any other way. For patients that are hemodynamically unstable with right heart thrombus and PE, we really open the floodgates open to advanced therapies, in particular surgical embolectomy. But for the hemodynamically stable patients, that's where it really becomes a question of what category are we going to put these patients into? And so it really comes down to sort of looking for other markers of adverse outcomes. So if you have a mobile right heart thrombus, or what sometimes gets called on echo as an impending pulmonary embolism with moderate to severe RV dysfunction, these guidelines would say consider urgent catheter-directed embolectomy. I would say at a lot of sites we would consider that to really mean urgent surgical embolectomy. We don't have as much of experience, although I'm going to show you some emerging data on catheter-based approaches to this. For PFO or right heart thrombus trapped in a PFO, really bulky right heart thrombus burden, concern that the thrombus isn't thrombus, that it's something else, tumor, or failed endovascular attempts, then we consider surgical embolectomy. At our center, we've largely relied on surgical embolectomy. We have cardiac surgeons that are very comfortable with doing open surgical embolectomy, and for that reason, it's been probably still is our first reach, although, like I said, there's growing experience with a number of catheter-based therapies. For really fixed or tacked down right heart thrombus where you don't think it's going to be easy to remove, small right heart thrombus burden, chronic appearing right heart thrombus, or low-risk PE, normal RV function, then anticoagulation with close monitoring is what's suggested. And I think that's a worthwhile recommendation, because a lot of times if someone's very low risk and has small thrombus, is that really worthy of open surgical embolectomy? And our PERT teams will discuss this, for quite a length to come to a consensus that typically we don't want to do something aggressive there. A note about anticoagulation, though. If we're going to pursue anticoagulation alone for these patients with clot in transit, we really do want to be mindful of some of the habits that we've got into that may be deleterious to our patients. So looking at our own PE response team experience, for patients that are intermediate high risk and high risk, over time, we've actually gravitated more and more towards unfractionated heparin. And that's a trend that's actually been seen at a lot of centers. And there may be reasons why we want to sort of curb that trend. So these were data that were published out of MGH's PE response team experience, showing that over time in the acute phase for PE treatment, very few patients actually achieve consistently therapeutic activated partial thromboplastin times. You can see this is not good, okay? 60% is the best we've seen with getting patients therapeutic, and most patients fall far below that. Do we really want that to happen in patients that have large clot in transit? Many would argue that what we want is something that's very consistently active, something like a low molecular weight heparin. And this was a very nice perspective on that article that I just showed you, saying that in pulmonary embolism and with unfractionated heparin, it's time to end the roller coaster ride. And really, that is what you see. PTTs that are subtherapeutic, then you overshoot, then you go back down and undershoot. That is not what we want in the acute phase of pulmonary embolism. And so, to quote the authors, perhaps most damning, only 1.3 and 0.7% of patients receiving the standard dosing and infusion-only regimens, respectively, had consistently therapeutic APTT values in the first 12 hours. Nonetheless, these data, along with the previous reports, clearly demonstrate that routine use of unfractionated heparin for acute PE needs to be curtailed. Unfractionated heparin is neither associated with less bleeding nor better outcomes than low molecular weight heparin or direct oral anticoagulants. And so I think within the construct of a PE response team, it behooves us to be mindful of the fact that unfractionated heparin may not be the best for our patients, especially those with clot in transit. So looking at options for therapy, it's a busy slide. I'm not going to go through each one. But in general, there are strengths and weaknesses to the different approaches for therapy and clot in transit. Like I mentioned, anticoagulation is effective, but it's effective over time and only if we get it to a therapeutic level. Our patients with bulky right heart thrombus, with mobile right heart thrombus, PFOs, we're not going to want to just rely on anticoagulation alone. The experience with systemic fibrinolysis is somewhat limited. Some of the issues with this is that if you give it and then you have the need to undergo or take the patient for advanced therapy that requires either a catheter-based approach or surgery, now you've increased their risk for bleeding. If they decompensate and need ECMO, now you're in a bit of a greater quagmire. Endovascular approaches largely focus on aspiration or mechanical thrombectomy. We see very little in the literature about catheter-directed fibrinolysis. The two big approaches for catheter-based therapy are FlowTriever, which is an it's large bore, but not the largest bore aspiration thrombectomy technique. And then there's AngioVac, which is a large bore embolectomy technique that really has sort of made its name in removing large thrombi from the right heart and from the IVC. There's another aspiration technique by Penumbra, the indigo aspiration system, lower profile, may not get some of the large thrombi. And then surgical embolectomy, like I said, has been our wheelhouse for a long time. So looking at a retrospective review for Clot in Transit, of almost 200 right heart thrombi in this series, there were 4 categories of therapy. Very few patients were untreated. They probably had an insane bleeding risk or some other issue. Anticoagulation alone was elected in about 35% of patients, some surgical approach in about 35% of patients, and then thrombolytic therapy in a smaller proportion of about 20%. Looking at mortality, you have to treat this. Mortality is extremely high. Anticoagulation alone, mortality still high, almost 30%. Surgical embolectomy, about 24%, and then with thrombolytic therapy, about 11%. Looking at catheter-based approaches, this series actually divided down into the 2 most common catheter-based approaches using FlowTriever or AngioVac. Certainly, I think they're very similar in many ways. They're large profile embolectomy techniques. They require large bore access. Groin bleeds and access site hematomas are almost expected with this type of therapy, and because they're both aspiration techniques, drops in hemoglobin can be quite significant. The AngioVac system has the potential to remove larger thrombi and has quite a growing experience for removing other types of right heart masses, vegetations, non-thrombotic right heart masses. And so here we can see an example of what can be removed. I mean, when you do it, it almost looks like what you might get out of a surgical embolectomy. Very promising, avoids the need for bypass, although oftentimes these are done with ECMO backup, especially with FlowTriever. With AngioVac. AngioVac's almost like essentially an ECMO circuit. Here we see another example, but this is in surgical embolectomy. Looking at Clot in Transit, we see the large saddle pulmonary embolism. We can see here it's actually going through a PFO, see it into the left side. This is not something that anyone would usually feel comfortable approaching with a catheter-based therapy, and surgical embolectomy is quite good for this, and here we can see what's removed. Very satisfying result. We do have a long record of surgical embolectomy in the Mass General Brigham system, especially at Brigham. You'll see that large RA-RV thrombus has been one of the standard indications for pursuing surgical embolectomy. Here's a nice video of sort of how satisfying. Now, this makes it look easy. It may not be this easy, but essentially under median sternotomy and cardiopulmonary bypass, incise the pulmonary artery and remove this large DVT that has traveled and lodged itself in the pulmonary arteries, en bloc. Very satisfying. Other situations in which this is used, failed medical therapy, failed fibrinolysis, presence of a PFO, even if the thrombus isn't going through the PFO. If there's large PE in a PFO, closing the PFO often is done at the same time. So to summarize the way we think about Clot in Transit in the absence of large randomized controlled trials is if there's no contraindication to fibrinolysis, it's really sort of what your center's comfortable with. Some centers out there have reported giving systemic fibrinolysis. That hasn't been our practice. There's a growing body of literature, mostly case series on catheter-directed therapies, embolectomies, and we've relied on surgical embolectomy. For relative contraindications to fibrinolysis, surgical or catheter embolectomy seems to be emerging as the top choice, and very, very rare do we see low-dose catheter-directed fibrinolysis used. And then when there are absolute contraindications, surgical embolectomy is what's been used, but I can certainly see catheter-based embolectomies, especially as you see refinements to FlowTriever and refinements to AngioVac, next-generation devices. I think those will be very popular for the management of Clot in Transit. And with that, I thank you.
Awesome. Thank you so much. Next, it's my pleasure to introduce Dr. Josanna Rodriguez-Lopez. She is an assistant professor at Mass General Hospital. She's the director of the Pulmonary Hypertension and CTEF program there. She's also the director of the HHT Center of Excellence. And she is going to be talking to us today about clot burden.
Thanks, Sasha. Do I?
Yeah, you just close it out and then it's on that.
Great. Thanks to Aaron and all the organizers for having me here today. And now we're going to switch gears and talk a little bit about clot burden and what it means in acute PE. Here are my disclosures, none of which are relevant to this talk. And I thought I'd start with a case because I'm a clinician and it seems always fun to present a PE case. So this was a recent PERT call we had, a 35-year-old woman with a history of fibroids who came in with vaginal bleeding, a new adnexal mass, and left-sided pleuritic chest pain and shortness of breath. Her vitals, she was tachycardic, blood pressure was soft, she was a little tachypnic and 94% on room air with elevated NT-proBNP. Here is her CT. So you can easily see saddle, pulmonary embolism, a lot of clot burden. This was the read from our radiologist, extensive bilateral PE with the saddle and a lot of distal clot as well with a dilated RV to LV ratio of 1.3. And here's our echo. So a dilated RV with impaired RV systolic function and evidence of acute RV strain with a large echo density in the main PA consistent with thrombus and an RVSP of 71. So clearly very sick patient. We have a young woman with an acute PE with a lot of clot, evidence of right heart strain by CT and echo with elevated biomarkers. So in this particular case, does the clot burden actually matter? How many people here think that would actually change your decision of what you would do or sway your decision? Raise your hand. Not too many takers. Okay, so I'm going to talk about clot burden and how it correlates with RV dysfunction. I'm going to go through different ways of how we even measure clot burden because I think that's kind of an interesting thing. Like there's a lot of variability, and then some clot burden and outcomes in PE studies, and then I'm going to end by talking about more chronic effects of clot burden. So when we talk about risk of PE, we're really talking about low, intermediate, high risk. The things that come into play are RV dysfunction, cardiac biomarkers, and vitals. And even in like the simplified PESI score that we use for risk assessment and prognosis in PE, you don't see anything about clot burden. It's really patient factors, vitals, and nothing about the actual clot itself. So does clot burden actually correlate with RV dysfunction? And there's a lot of small studies trying to answer this question. I just put two representative ones here. One of them measured clot volume and looked at both CT parameters and echo parameters and found that higher clot burden correlated with the dilated RV by CT, but didn't really correlate with other echo parameters that we traditionally use to assess RV function. The other one actually looked specifically at fractional area change and did find that clot burden correlated with a change in fractional area change, so a good echo parameter of RV function. So how do we measure clot burden? And it was fun to go back and look at the study, the initial study in massive PE that randomized patients or looked at patients treated with streptokinase versus heparin, and that's how the Miller Angiographic Index was actually started. They wanted to see if patients who got one treatment versus the other had improvement in the clot burden by angiography, which was considered the standard at the time, the gold standard. And this is a schematic of how the Miller Angiographic Index is calculated. So you calculate both, you get points both for where the clot is located and also how much flow is going through the lung. So first, where the clot is located, any segmental branch gets a point, And if you have a more proximal branch, you count all the distal segmental branches after that. And then for the flow, the lungs are divided into 3 sections, upper, middle, and lower. And there's points for having normal flow, reduced flow, severely reduced flow, and absent flow. And then you sort of add all those points together and you get a score from 0 to 34. And so that's the Miller angiographic score. Obviously, we're not doing pulmonary angiograms on acute PE that often anymore, so different groups have tried to correlate this with our CT pulmonary angiography, and this is a very commonly used score, the Konadli score, where they looked at CAT scans on patients with acute PE and came up with a very similar score where you got scores both for clot location and also for perfusion or filling defects, which they classified as 0 if no clot was visible, 1 if it was partial filling defect, and 2 if it was total occlusion. And then you add all those points up. This one goes from 0 to 40, and you get a score. And what they found is that this obstruction index using CT pulmonary angiogram was very reproducible and highly correlated with the Miller angiographic index. And they also found that if you had a CT obstruction index of greater than 40% or a Miller angiographic index of greater than 50%, those patients tended to have RV dilation. Although in this study, they used an RV to LV ratio of 0.6, which is not what we necessarily consider now to be an abnormal RV to LV ratio in acute PE. But all these patients in this study had both a CT and a pulmonary angiogram. Another frequently used score, and I'm sorry, this is a typo, is the Mastor score, is also similar. I'm not going to go through the details, but basically it calculates percentage of obstruction on each vessel. And in this study, they tried to see if having a higher score correlated with clinical parameters or with some of the risk tools that we have. And what they found was that it didn't correlate with Wells score, Geneva score, PESI score, and most of the clinical parameters didn't correlate, except having an elevated lactate was the only one that they found that correlated with having a higher score using this system. Now, this seems all very complicated, sitting there, like trying to look at each segment of the lungs. It's time consuming. It's not something you necessarily want to be doing when you have a sick patient in front of you. So what about using just clot location? Proximal versus distal, does that make a difference? And so this study from MGH looked at giving a score from 1 to 9 based on where the clot was located. Saddle PE being the highest, and then a single subsegmental PE being the lowest. And what they found was that central PE seemed to be associated with greater adverse events, which included cardiac arrest, intubation or use of positive pressure ventilation, arrhythmias, use of vasopressors, and thrombolysis or thrombectomy. I always think that as an outcome is a little tricky because I think people are usually biased. When they see a lot of clot, they may want to do more aggressive treatments. So using that as an outcome is not necessarily a great outcome. But what was interesting is that even though it had all these correlations with worse adverse events, it didn't correlate with an increased 30-day mortality. This is an even simpler way of looking at clot location, the mean bilateral proximal extension of the clot. It's just 4 points. You get a 4 if you have clot in the main PA, 3 in the lobar, 2 in the segmental arteries, and 1 in the subsegmental arteries. And by looking at the score, a high score, meaning 4, correlated with some PE severity parameters and short-term outcomes, but not all. So they found that it correlated with having an elevated troponin, an elevated RV to LV ratio, admission to ICU, and thrombolytics. But again, in the study, they also did not find a correlation with mortality. So it seems like some clinical parameters that with central clot make you sicker may be correlated with being sicker, but not really a change in survival. So I've said how kind of time-consuming calculating clot burden is. So can we use AI and deep learning techniques to sort of speed this process up. And this was an interesting study where they used a deep learning algorithm to calculate clot volume using CTs, and they compared it to two radiologists who were manually calculating both the Connolly and the Mastora scores. And what they found is that this deep learning algorithm greatly correlated with the radiologist's read, and that the difference in time with the algorithm was 12 seconds to get a score compared to 10 minutes for the radiologist. So if any radiologists are out there, I would be sweating a little bit after this. But this may actually help us to study this more easily in the future if we have this available. All the studies I've presented are kind of small retrospective studies, so there was this meta-analysis that tried to answer this question, and they looked both at clot location and obstruction index separately to see if there was any correlation with 30-day mortality. And the obstruction index, again, did not correlate with mortality, but the clot location, interestingly enough, did seem to correlate. However, the caveat being that they removed a lot of the trials for the clot location because the trials were so heterogeneous. So this meta-analysis really only had 3 trials in it. So hard to say if this is a real finding or not. So many ways of measuring clot burden. I think I've made that clear, showing you all these scores and different ways we can do this. And there seem to be conflicting results from the studies about the importance of clot burden in terms of PE outcomes. Now, I do chronic thromboembolic disease, and so my question about this was, does it matter now? Does clot burden actually matter for more long-term issues? Does it increase your risk of CTEPH? Does it increase your risk of having problems later on? And this was a nice study where they looked at a pretty large cohort of patients with acute PE who had follow-up ventilation perfusion scans within 3 to 24 months after their index PE. And about half the patients had a calculated obstruction score with their initial scan. And when they looked at these patients, those patients who had an initial pulmonary vascular obstruction score of greater than 20% actually had a much higher risk of having residual pulmonary vascular obstruction of at least 5% in the follow-up imaging. So it did seem that having a high clot burden initially increases your risk of having some residual clot more long-term. And there is data also showing that increased pulmonary obstruction at discharge after your acute PE. So if they do some sort of imaging in the study, they did a VQ scan prior to discharge. If you have greater than 35% of obstruction at that scan, it actually correlated with worse outcomes at 6 months, which included death, recurrent PE, or heart failure. So it seemed like those patients who had quick resolution or not that much clot at the time of discharge did better than those who had a lot more clot at the time of discharge. And we all know that having an initial high clot burden has been shown in some studies to correlate with the development of CTEPH. This is from the very well quoted Pengo trial from the New England Journal in 2004, where they followed 200 patients with acute PE over 2 years and found that 3.8% of them developed CTEPH, and having a large perfusion defect in it with your initial PE seemed to be a correlation with development of CTEPH. And this has been taken even further by this more recent study in 2023, where they looked at a lot of patients, again, with acute PE and followed them. And they had a slightly increased risk of development of CTEPH in this study, but they did find that having a higher Connolly score with your acute PE correlated with development of CTEPH, and particularly in males, it seemed to be predictive of development of CTEPH. So in summary, I think I've shown you that there's multiple published techniques on how to measure clot burden. You can measure obstruction index, clot volume, clot location. You can use CT. I didn't show VQ, but obviously you can use VQ or pulmonary angiogram. It's not really something that's readily available and used in clinical practice because it's time consuming and dependent on radiology expertise. most of these studies are using different techniques, and so it makes comparing and reproducibility difficult. It involves patients that we don't have details of and have unknown hemodynamic parameters. So these may be a bunch of very stable patients mixed in with sick patients, so it's hard to compare. And most of them are retrospective and not stratified for comorbidities or treatment. And as you can see, there's been very inconsistent results. However, high clot burden may predict residual pulmonary vascular obstruction, which has been identified as a risk factor for development of CTEPH. I think if we want to really answer this question, I think we need to be able to measure this more objectively and fast. And so maybe AI and deep learning techniques will come into play to be able to study this in a more rigorous fashion. And I think larger prospective studies need to be done, maybe stratified by clinical factors and treatment strategies in order to better understand if clot burden really is an important decision-making thing in PE that would affect PE outcomes. And with that, I thank you.
With that, it is my pleasure to introduce Dr. Behnood Bikdeli, who has been very active in the field of thrombosis in both the heart and elsewhere.
Thank you so much. Good morning, everyone. Pleasure and honor to be with you. Very hard to follow after the first great talks. So I'm going to talk about provoked versus unprovoked venous thrombosis and whether it really matters, whether we really need to care about that. Here are my disclosures, none of which are related to this talk. And what I would love to discuss is first the definitions, getting the basics right. What are we talking about, provoked versus unprovoked? And then seeing if those actually impact the recurrent events, and then discussing how we can come up with kind of categorization for clinical practice in this day and age. So first off, to talk about the definitions, they were really dissecting maybe, based off of whether there was a major provoking factor. And some of the guidelines, including ASH and others, were supportive of that. Some of the older literature was kind of thinking of it synonymous to idiopathic VTE. So if you were having a major provoking factor, that was provoked. If you did not have any of those, and these are, by the way, surgery, trauma, acute lower limb immobilization or fracture, joint replacement, and spinal cord injury. If any of these were there, they were called provoked. If none was there, unprovoked. They used to also call them idiopathic. And one of the questions is, can it affect the ultimate outcome that we are concerned about when we see VTEP-related mortality? The answer is no, at least not to my knowledge. But in terms of subsequent recurrent venous thromboembolic events, there are many individual studies, and for the sake of time, I thought it's not worth your time to go over them. This is a systematic review and meta-analysis from JAMA Internal Medicine, formerly Archives, and you can see that per 100 person years of follow-up, the point estimate for people with provoked VT was 3.1 with a wide confidence interval. But when you look at a separate systematic review and meta-analysis for people with unprovoked venous thrombosis, the point estimate is 10.3. And granted, these are two separate studies, but if you look, the confidence intervals are far from overlapping. So probably there is some weight to this designation, even if it's imperfect. And to that point, there was a very nice summary in circulation by our own Dr. Piazza and others that suggests that lumping all these heterogeneous group of people into provoked versus unprovoked, it might not really tell us the whole story. Where are the guidelines? The short answer is they're all over the place. But to get to the detail, ESC guidelines, I found them very interesting. They actually tried to move away from the dichotomy of provoked, unprovoked, and I'm sorry that this does not project large enough on the screen, but big picture, they're grouping people into low risk, intermediate risk, and high risk, and one of the things that they do include is people with enduring risk factors. We will get back to that in a few minutes. Other guidelines, including CHEST, have different recommendations, and even if you look at guidelines from AC Forum, NICE, etc., Bottom line, there is heterogeneity in terms of whether or not they use provoked versus unprovoked and how they deal with it. And part of the challenge is high quality comparative effectiveness data are limited. So we do not have a ton of studies that distinctly powered for clinical outcomes randomized for provoked versus unprovoked. And one of the questions is, when you see unprovoked VTE, is it really worth to go and chase a hidden cancer? That's been a subject of some randomized trials, including in NEGEM. And one of them was a multi-center randomized trial from Canada with over 800 people who were randomized to limited screening based off of clinical thoughts of the clinicians, plus CT abdomen pelvis versus not. And bottom line, there were very few cases with cancer that were missed based off of routine clinical care, and there was no significant difference between the group who got screened more intensely than the group that was not. Maybe to me, the more exciting study that is coming up is one which is a registry-based trial where they're using PET. So stay tuned, maybe another 2 years or so, we will have more information to share. But for now, it seems like routine additional screening above and beyond age-appropriate screening should not be standard of care. How about thrombophilia testing when we run into unprovoked? The downsides are cost, and a lot of times you will see that they're low yield. Sometimes they're actually misleading, especially if you're checking the biomarkers and patient is acutely ill, inflamed, taking OCPs, you name it, everything under the sun, and hematologists are smarter than I am, but you can get a lot of false positives. And it causes anxiety for patient, family, cascade screening in families, it does not help. But what are the potential benefits? I think one of them is if you do find a strong thrombophilia factor, it might actually impact the way you communicate risk to patients, which may ultimately downstream change your anticoagulation management plan. And the other one is even if somebody is having like recurrent major procedures, etc., again, in the absence of high quality data, some experts think that it might be worth considering this for duration of prophylaxis. And changing the type of anticoagulation is another one. I would not go much off topic. Suffice it to say that in a recent meta-analysis of randomized trials, these for people with APS, DOACs are inferior to vitamin K antagonists. That's a small subgroup, but something worth considering if you're suspicious of it. And pathophysiology would get more clarified. And it's helpful for family as well. But to what extent do we need to do it? And these numbers are small and intentionally small. Long story short, you check a lot of people and only a few test positive, but a graph is worth more than 1,000 words. So I tried to show it graphically here. If you look at people without a family history, and this is based off of RIATE, the largest registry in the world, you see that only a very small proportion of people end up testing positive among the people who get tested. And this is in sharp contrast to people who do have a positive family history. It's still a minority, but the pie is telling in and of itself. It's a larger proportion of people, and it's highly significant when I made the statistical comparison. How about the randomized trials? And here I'm showing, again, I'm sorry that this does not project large enough, but I will tell you the story. This is subgroup analysis results from the Einstein choice trial of rivaroxaban versus aspirin. And if you look, they enrolled a lot of people with provoked and a lot of people with unprovoked VTE, and they do not show, NEGEM does not anymore report treatment interaction p-values, but it does not have an interaction when this was published. And same thing in the appendix. If you look at the bleeding events, more of the same, but I think devil is in the detail. These are relative treatment effects. If you look at the absolutes, the event rates among people with provoked VTE were lower, but the bleeding event rates were kind of similar. So the real question is the treatment benefit still the same when you want to communicate the risk to patients and make an informed decision together with your patients? Similarly, in the trial for apixaban, the treatment effect overall for the doses of anticoagulation with 2.5 or 5 versus placebo were very large. However, only a very small minority of people in this trial had provoked venous thromboembolic events, which is a nice segue to the HiPro trial, and we have the PI in the panel with us. So this trial is actually going back to what the European Society of Cardiology was talking about. People with provoked VTE who at the very least have at least one enduring risk factor, such as heart failure, and randomizes them to continued anticoagulation for additional 12 months with apixaban 2.5 milligrams twice daily versus matching placebo. And the primary outcome of interest is clinical outcomes. Almost done with enrollment, and I think by another 1.5 years or so, you're going to hear about the results. I talked a lot, so let's try to recap and see what we have. So a lot of people have VT with a major provoking risk factor, again, trying to steer off of controversy. I didn't get to OCP. Some people think it's a smaller risk factor, provoking risk factor. But let's put them in one group. The other side of it is we have cancer-associated VTE, very different disease, and we should treat it very differently. But then in the middle, we are going to have a bunch of people, for now, let's call them seemingly unprovoked. It's people who are not in group 1, not in group 3 either. And for those, in the right setting, I think it might be appropriate to consider thrombophilia testing. It's not just a reflexive response, but in some of them, and age-appropriate cancer screening. If none of them come, then I think it's fair to consider them unprovoked, but do not discount the enduring risk factor. So it's not a simple dichotomy as we were talking about. Whether or not people fit into these three categories, there could be enduring risk factors that can inform your thought process for risk of thrombosis. And by the same token, you need to be cognizant of risk of bleeds as well. It's not a one-size-fits-all. So you have all the way from the least worrisome types of venous thromboembolic events in imminent time versus the most concerning, and same for risk of bleeding. So we need to factor all of those in such that we inform our patients toward the best decision possible. And I'll just give you a couple of examples of the spectrum, would not belabor, but more of details. Isolated distal DVT versus proximal DVT. A lot of people were like, DVT is DVT, why do I care? So this study based off of RIETE, the same largest registry that I was referring to, we had over 5,000 patients with isolated distal DVT, so nothing proximal, no PE, and we had over 27,000 patients with proximal DVT, no PE, no other venous thrombi elsewhere. And long story short, if you look at the KM curves, you see that the incidence of subsequent recurrences are much higher in people with proximal DVT. That's not a major surprise. Several other studies had reported it as well. But we had the luxury of large sample size. So I think here is the take-home message. Once you adjust for multiple potential confounders, the risk of mortality, and more importantly to me, which is probably causal, VTE recurrences is still substantively lower in people with distal DVT. And this is in sharp contrast to bleeding, because guess what? You cannot causally tie bleeding events to a DVT. It's all confounding based off of treatment or differences in case mix. So for bleeding, once you adjust, the difference goes away. This is unlike subsequent VTE events that I was referring to. And completely separate issue, but same theme. It's not a simple decision, there is a VTE, let's treat, or it's an unprovoked VTE, let's treat indefinitely. This is a thought-provoking analysis that came up in the annals a few months ago. It's modeling a lot of assumptions and decision analysis, and it's from the healthcare perspective from Canada, so a lot of differences. But the take-home, they're showing that even for people with first unprovoked VTE, it's not as simple as saying, yes, all of them should receive indefinite anticoagulation. Excuse me, here in this analysis, it did not improve quality-adjusted life years. So it did reduce VTE events, it did reduce PE, it did reduce PE-related mortality, but it was not a free lunch. That is why it didn't alter. And patients' perceptions are usually not in favor of lifelong anticoagulation, even putting the cost aside. That's why ultimately it didn't improve quality. So the take-home message is, I think provoked and unprovoked designations do carry some weight, but they're not telling us the whole story. And we should think about the enduring risk factors, bleeding events, and patient goals and values are key. And we have a bunch of ongoing randomized trials that hopefully will put us in a better position to help our patients. Thank you so much.
Thank you. It's my pleasure to introduce our last speaker for this session, Dr. Alison Witkin. She is the Associate Director of the Pulmonary Hypertension and CTEF program at MGH. She's our Associate Fellowship Director, and she's going to talk to us today about the duration of anticoagulation.
Great. So thanks to the organizers for inviting me to talk. And I think that so many of the things that we're presenting here over these 2 days we're talking at really small groups where we don't have large randomized controlled trials. We don't have a lot of guidelines telling us what to do. This is kind of the opposite, and I think highlights that even when you have large randomized controlled trials, it's often still not that clear what the best thing to do is. So what I'm going to do is I'm going to discuss the state of the current guidelines on anticoagulation duration, talk a little bit about some of the nuances that dovetail nicely from our last talk about decision-making regarding that duration. We'll talk a little bit about decision support tools and how they can be used. And I think one of the things that goes throughout this is there's lots of special populations. And I'm sure for every single guideline, every single piece of data that's out there, we can all come up with multiple examples of patients where we probably should set those aside and put just the patient's clinical scenario first. So when we think about guidelines on duration, PE is a space and DVT is a space that I think a lot of specialties feel like they own. We have guidelines from pulmonary, we have guidelines from cardiology, we have several guidelines from hematology, and there is a fair amount of agreement between them, but there are some important areas where they differ, and I'll try to highlight some of those. And I wanted to just go back to I think myself, at least, I always took the acute PE, acute DVT, 3 months of anticoagulation for granted. And where does this actually come from? And so I think it's helpful to think about anticoagulation duration in 2 phases. The first is the initial treatment phase, and the second is our longitudinal, more long-term chronic phase. So in the initial treatment phase, the goal is to ensure stabilization of clot and allow time for lysis of clot to occur. This was a randomized trial that looked at what the right duration is, and this looked at 6 months, which is now a little longer than we typically do, but compared it to 6 weeks. And one of the trends that you'll see in all of the Kaplan-Meier curves that I'm going to show you is that as soon as you stop anticoagulation, you start seeing a rise in the incidence of recurrent events. However, when they only did 6 weeks, what you see is that rise happens really, really sharply. And that in this study, which was 6 weeks versus 6 months in patients with a first VTE, at 2 years, there was recurrence in 18% of patients who have been treated for 6 weeks, as opposed to only 9.5% in the 6 month groups. And most of that split happened early. And this was excluding people in all of the trials for anticoagulation duration. Patients who had significant known baseline hypercoagulable states were excluded. And so this is really where the 3 months comes from, so now the guidelines are that 3 months of anticoagulation should be used for all patients unless there's prohibitive bleeding risk. And the risk of recurrence really stops as soon as anticoagulation is stopped. So this is a study that was published in BMJ that included patients with DVT or PE, again, patients who had a known ongoing risk factor such as malignancy or chronic immobility were excluded from this, and patients were treated either with low molecular weight heparin or Coumadin and were randomized to either 3 months or 6 months. And I just want to highlight that in both groups, as you see, as soon as you hit the 3 months and that's the green line, and as soon as you hit 6 months for the yellow line, that the risk starts going up, and it goes up fairly significantly. But those 2 lines really parallel each other. And there was really, after 1 year, there was no difference in the recurrence risk, whether you were treated for 3 months or for 6 months. And importantly, there was a significant increase in the rate of non-fatal bleeding in patients who were treated for 6 months. And so this is where our sort of standard guidelines, which are 3 months of anticoagulation for your run-of-the-mill patient with a PE or DVT for the initial treatment phase, comes from. And there's very, very good consensus about this across all of the guidelines. Where it becomes a lot more complicated, and I can say this is one of the decisions that I find most stressful because you don't want to be wrong in either direction, is what to do in that more chronic phase. So after the initial 3 months, the first thing is to perform some sort of risk-benefit analysis about extended duration anticoagulation. What do I think the patient's risk is of having another clot versus what do I think that their bleeding risk? Patients who have most people agree that patients who have a clearly provoked event from a reversible risk factor do not require extended duration. But here our goal is switching, and that's really why that risk-benefit analysis comes into play, that our goal is not to do anything about the clot that has already happened and occurred. Our goal is to prevent new events rather to improve any outcomes from the initial event. And so really it's this bleeding versus clotting. A lot of the things that we've already heard about is this someone who has, for example, a higher risk of clotting, antiphospholipid antibody syndrome, other inherited hypercoagulable states, malignancy, chronic inflammation, or unprovoked, where we really haven't been able to find any factors. Or is this someone who has a higher risk of bleeding? And some things for that will be concurrent use of antiplatelets, often for a separate indication. What's their fall risk? Do they have a personal history of bleeding? I'm not going to get into so much the recurrent clotting risk because we just had a whole talk about what makes provoked and unprovoked and trying to figure out that risk. There's not great tools right now to assess for bleeding risk, particularly in the era of DOACs. A lot of times, I'll be honest, I end up using like my clinical gestalt because most of the bleeding scores that are out there, including VTE bleed, which is sort of the one that's been, I think, most widely used for PE-specific bleeding, either did not include DOACs or very, very minimally included DOACs. So VTE bleed, for example, only looked at dabigatran, and none of the other DOACs were included. And so with vitamin K, so we know we have fairly good data with vitamin K antagonism with warfarin, but very poor data for how to predict bleeding with DOACs. I just want to highlight that there was a score that recently came out that was published within the last year in Circulation, looking at something called the DOAC score. Now, this was developed for non-valvular AFib, so not necessarily the same population, but it looked at a lot of the things that I think we include in our gestalt, so age, renal function, whether or not they're already on antiplatelets, bleeding history, liver disease, and came up with a score that helped predicted the risk of a bleeding event. And this was validated across multiple DOACs. Importantly, though, this was not included in PE, and so it's hard to know if we would have the same results or not. And so this is one of the areas where the guidelines sort of agree, but are also a little bit all over the place. So right now, they recommend extended duration anticoagulation is recommended for recurrent VTE not related to major transient reversible risk factor. And I think most of us would agree if we have someone who's had more than one unprovoked PE or DVT, most of us are going to agree that person needs to remain on some sort of lifelong anticoagulation. And antiphospholipid antibody syndrome is also another fairly clear decision-making. And then where it becomes a lot less clear is extended anticoagulation should be considered for patients who have an initial PE without a risk factor, the quote-unquote unprovoked PE, patients who have initial PE with a persistent risk factor. And then I want to highlight the one where there is the most gray and the least agreement between the guidelines is PE with a minor transient or reversible risk factor. The person who has a PE after they have flown on a cross-country flight, but they've flown on cross-country flights numerous times. Like, why did they get a PE now? Do we say this is provoked? Do we say this is unprovoked? And the guidelines vary on how to address this. So just to highlight a couple of the guidelines, the European Society of Cardiology guidelines recommends considering anticoagulation for those patients. ACCP, the CHEST guidelines, say those patients don't need anticoagulation. And then ASH doesn't even mention these patients. And so this is really the patient population that I personally struggle the most. And I'm really interested to see the results of the trial that Dr. Piazza is the PI for, looking at some of those patients to try to figure out how to best treat them. And so this is an area as well where over the last 10, 20 years, we've seen a real change in what our options are. And this may change even more in the future as we come up with medications that are better and better at preventing clots with lower and lower bleeding risk. That calculation and that risk-benefit analysis is really going to change. So antiphospholipid antibody syndrome is not a good diagnosis to have, but it's fairly straightforward right now when it comes to decision-making. Those patients need lifelong anticoagulation. And we have reasonable, both retrospective as well as some randomized controlled data that vitamin K antagonism is recommended over a DOAC. There was one randomized controlled trial that was prospectively done, looking at patients who had triple positive APLAS, so the most severe of that phenotype, and patients who were treated with rivaroxaban both had more clotting and more bleeding. So for the most part, I don't use DOACs in those patients. Then when it comes, do we use a DOAC versus warfarin for our long-term anticoagulation? There was a trial, which I put up here, comparing dabigatran versus warfarin. Dabigatran had less bleeding, and it was non-inferior for VTE prevention. And so for the most part, I think people are primarily using DOACs at this point, although the guidelines don't really say like if you should keep someone, if they're on warfarin, they've been doing well, they don't have a contraindication to DOAC, the guidelines are not completely clear about whether or not you should switch them. Aspirin, I just want to mention, is still in the guidelines. In the figures I have up there, you can see recurrent VTE. Those are recurrent VTE and bleeding, comparing the two. There's some other data which has been talked about already, which looked at aspirin. Aspirin is definitely not as good as a DOAC in preventing recurrent VTE, but it does have some role. It's better than not being on anything. And I think where this comes into play is your patient who has a primary indication for being on aspirin, and it's equivocal in your mind whether or not to continue anticoagulation. They are getting some protection from the aspirin, and it does still remain in some of the guidelines as an option. But what's really been, I think, a game changer is that this ability to now dose reduce for long-term prevention. I think that's bringing us closer to that goal of having medications that prevent recurrent clots without increasing bleeding. And so both rivaroxaban and apixaban have been studied with the use of reduced dosing for extended duration in patients who have clinical equipoise. One of the challenges, though, is it's not clear exactly how that equipoise in the studies is defined. As we saw earlier, the majority of those patients in the trials were quote unquote unprovoked VTE. And so it's really hard to know for that patient who has the minimally provoked clot, like, is that someone who would have been enrolled in the trial or not? And how do we think about things? So the guidelines give weak recommendations to do this. And then I think one of the areas where I don't know of any trials, but I always wonder about is what to do with someone who is going to stay on warfarin. I have patients, I'm sure many of us do, who really like going to get that INR checked and seeing that number that tells them they're in the right range, and try as I might, I cannot convince them that they should switch off of warfarin. It kind of doesn't feel right intuitively that we should dose reduce our DOACs, but not change our doses of warfarin. But the guidelines recommend that if someone's on warfarin, you keep them still at that same INR. And this is just to highlight some of the two studies. I put one up for the rivaroxaban data, which looks at recurrent fatal or non-fatal VTE. And you can see that 10 and 20 milligrams of rivaroxaban perform very similarly and significantly better than aspirin. The one on the bottom is looking at the data for apixaban for bleeding. And I just want to highlight that the bleeding incidence of 2.5 of apixaban was almost the same as placebo, basically. And so we're really not seeing significantly increased risk of bleeding in these patients. Now, granted, this is a selected patient population. If it was someone who you already thought was at very high risk for bleeding, there wasn't really clinical equipoise, and they likely would not have been included. So sometimes it's clear what to do. A lot of people have tried to come up with, and there's a variety of decision-making tools out there to try to take what we know from the data and then take individual characteristics of each patient to try to give more personalized answers as far as someone's risk of having a recurrent clot versus bleeding. I will say the guidelines are not recommended for routine use, but they can be helpful in counseling individual patients when you're engaging in shared decision-making. There are several calculators out there. The D-dimer is also a fairly easy test to get and can provide us with a lot of information. This was a study which looked at D-dimer 1 month after stopping anticoagulation. Patients who had a normal D-dimer still had a reasonable risk of recurrence of just over 5%, but patients who had an abnormal D-dimer level after stopping anticoagulation had a risk of recurrence out to a little less than 2 years of about 15%. and that risk could be mediated by resuming anticoagulation. So the one that I use personally most clinically is the D-dimer, but I only order it if it's a situation where the result is going to affect my management. If it's someone who I've already decided has a bleeding risk that's too high for them to remain on anticoagulation, I don't get it just to get the test result and then make everybody more nervous. Again, like the bleeding risk predictions though, this data is predominantly from prior to DOACs. And so as our risk of bleeding gets lower and lower, using some of these tools, it's unclear exactly what their role should be. And as far as the guidelines, what they say is it should really be used, these use of decision-making tools should really be reserved for select cases that are very borderline and as part of shared decision-making with the patient. And then to end, I just want to highlight that this talk, I think, given 15 years ago would have been a very different talk, and I anticipate if this talk is given again in another 10 to 15 years, it's going to be a really different talk. So there are multiple drugs right now that are in development that are targeting different sites in the coagulation cascade, trying to get more and more to that idea drug that prevents clot without increasing bleeding. I think the one that's closest to prime time, and I just want to mention, is abelacimab, which is a monoclonal antibody to factor 11 and 11A. So it's injectable, which is inconvenient, but it's just given once a month. So you take it once a month, and then you don't even have to think about what medication you're taking the other 30 days of the month. It was studied in AFib for stroke prevention, and it was stopped early given such a strong signal for benefit, being effective at preventing strokes with decreased bleeding. It hasn't been studied much yet in the VTE space. There was a study looking at it as far as prevention, so prevention for VTE compared to enoxaparin in patients undergoing knee surgery, and it was found superior to enoxaparin. And there's currently an ongoing study that's enrolling right now looking at comparing this medication to apixaban in cancer-related VTE. So I think we'll have more information about this drug as well as hopefully other numerous medications. So to summarize, the currently available expert guidelines are a good starting point for clinical management, but they have to be applied individually to each patient. All patients, unless they truly have prohibitive bleeding, should receive 3 months of anticoagulation. There's very good data to support that shorter time periods are not adequate. And the longer duration for extended duration anticoagulation depends on the risk-benefit analysis. Reduced dose DOAC is appropriate for secondary preventions, and many, I would say probably even most patients who require some sort of long-term preventative anticoagulation. But there's a lot of ongoing trials. I am really hopeful that even within the next year to 2 years, we'll have a lot better information to guide our decisions, as well as hopefully some new medications. Thanks.
This is a great session. So I have a question. We know that in the echo world that some of our parameters suggest acute versus chronic PE. So for example, the right atrium really should not be dilated in an acute state. There's some other findings like the 60-60 sign where your PA pressure should not go above 60 in an acute setting. And if it is high, it indicates a double hit phenomenon or something more chronic going on. So in your patient, the young lady who came in with a PASP of 72, she had a dilated right atrium and dilated RV. Are there any studies that you guys are performing in your center where you look for acute versus chronic changes using echo risk stratification?
Yeah, that's a great question. And I think, that shows the point that a lot of times there are there could be chronic components in an acute presentation even with that PENGO trial that looked at incidence of CTEPH. A lot of the people think that maybe some of those acute Ps were actually already chronic. So I think paying close attention to echo findings and also, imaging findings of eccentricity in the clot or what the clot looks like is very important. We have a standard protocol for patients who come in after, for instance, a PERT activation. And so anybody who had an abnormal echo will automatically get an echo on follow-up to ensure that after the acute event, the RV normalized, and if it didn't, to do the appropriate testing, for instance, VQ scan, and kind of go down the route of the CTEPH algorithm.
Sort of in the same area, do we think that even the studies about clot burden, whether that clot burden matters as much as the pre-existing evidence of perhaps CTEPH? And I think a scenario that all of us have been in is trying to sort of curtail the aggressive interventions for patients who we suspect have acute on chronic PEs.
Yeah, that's a great point, and I'll also let other people comment on that. But I think just because having large clot burden may increase your risk of development of CTEPH, we really don't have data showing that treating that clot more aggressively with thrombolytics, for instance, will improve your chances or decrease your chances of getting a chronic component.
No, I think I was sort of suggesting it the other direction, that the outcome studies didn't look at CTEPH in the setting of larger or smaller clot burdens, and the pre-existence of CTEPH with clot burden superimposed may have been more the determining factor of how patients did than the clot burden itself.
That's a great point. Thank you, Evelyn.
Can I chime in real quick? At the risk of complicating things further, I'm going to ask Nick to talk just a little bit about, this idea that, there's clot burden, but where the clot burden is may matter, and just generalized clot burden may not be as specific a term. There's work that Nick and George Washko have done, and I've been fortunate enough to spend a little time learning from them, looking at distal, ways of assessing distal clot burden that may be more predictive than proximal clot burden. Nick, take it away.
I think my moderator job was just stolen.
I did take it, yeah.
No, I think there's definitely a couple of points that have been brought up. One of them is that our ways of looking at the impact of clot burden on outcomes really have focused on the visible clots themselves, whereas the talk that Josanna gave, actually, the old way of doing it with pulmonary angiograms, flow was an important part of it, and perfusion was a big part of it. And when we just focus on, okay, these are the clots we can see, whether by AI or by our eyes, we're missing that component of how much is the circulation actually impacted. And I think there are ways of trying to ferret that out using CT imaging, of course, is my pet way of doing it, but there are other ways of doing it as well. The other point I wanted to comment on is this idea of chronicity versus acute. I think that's another area where, particularly if we have automated methods of making these risk assessments, the problem is that acute PEs are triaged often in the community. And by the time they come to us, they come as acute PE. And the people who have the eye to look at eccentricity and webs and ask those kinds of questions are not the ones making those calls. And so we often come in sort of, well, hopefully not post-mortem, but the cat has already left the bag. I mean, it's like, this person went in for, yes, post-failed ecos. It's like, why didn't this person respond? And it's like, well, so I think we need better markers that can be deployed not by people who spend their whole life staring at these things, but by the community to get around this problem.
And if I can just add one thing, I think this factors in so much into even things like anticoagulation duration. I always struggle with whenever recurrent PE is used as an endpoint in a trial, because I think, I've seen so many patients where they're being diagnosed, they've been switched from warfarin to apixaban to enoxaparin because they, quote, keep having new PEs, and you look at it and it's all in the same spot. It's not new PEs, it was just chronic PE all along. And so as long as that's used in a clinical trial outcome, there's often not good adjudication for differentiating what is still a chronic PE that was there the whole time versus a true new event.
I have two questions.
Oh, no.
Yes, it's true. The first, and I'm just going to say them both, and then you can deal with it. The first has to do with why are we so bad at anticoagulating people in the acute setting? Is it our algorithm? that we use the weight-based approach, and is there a better approach? Should we be using IV low molecular weight heparin? Because I know we all want something on there as quick as we can get it on, especially if we're not going to thrombolyse a patient. So that's the first question. The second has to do with the duration of anticoagulation. I was kind of struck about the recurrence rate after 6 months of anticoagulation versus 3 months, and that there's still a substantial recurrence rate according to those graphs. So would it be better for us to increase the duration for everyone and maybe think about de-escalation to lower dose, or even think about a role for aspirin in that group?
Both are great questions. Maybe I will take a first stab at the first one and then defer to the rest of the team. When we go to international conferences, colleagues both from Europe and Canada kind of put us in a difficult position because of overuse of unfractionated heparin. And I get it. If there are people who are at the cusp of requiring procedures, be it ECMO or other advanced therapies, it makes sense to use something with a short half-life. But I think this has just become a reflexive response in the US healthcare system to put almost everyone on fractionated heparin. Even if we don't have IV LMWH, I feel very comfortable with subcutaneous, and I think it's appropriate for many people except for high-risk PE and those who have intermediate high transitioning toward further deterioration.
Yeah, I would just echo that most of the contemporary randomized controlled trials that are undergoing now, looking at catheter embolectomy or catheter-based fibrinolysis for acute PE, now actually recommend low molecular weight heparin as the primary mode over unfractionated heparin. HiPytho does that, or at least says it's equivalent. And I think that we're so afraid that we're going to have to turn anticoagulation off because of a bleed that we're using something that's inherently ineffective.
I feel like at MGH, when we looked at our heparin data and found how horrible, patients were really not getting therapeutic, we completely switched to enoxaparin, and we really haven't seen increased risks of bleeding, even in the patients that go and get catheter therapies and other things.
Yeah, and I can take the second question about anticoagulation duration. So if you look at the risk of recurrent events from time of enrollment, the patients who were treated for 3 months had more PEs at a year than those who were treated for 6 months. And I think that's not that the 6 months is better at preventing a recurrent event. It's that those patients treated for 6 months only had 6 months at a year off of anticoagulation versus those treated for 3 months only had a full 9 months off of anticoagulation, so they had more time for it. The curves parallel each other very nicely as far as basically the day you stop, the risk increases, but the risk doesn't increase any faster in the 3 months compared to the 6 months. And at 2 years, it's the exact same. And I think it's kind of scary how common recurrence is. Even if you look at people with very provoked events, their risk is still remarkably higher than the general population. And I'm always so reluctant. Sasha and I share an office, and we always share our stress and anxiety about stopping anticoagulation in these people, even when it's the most clear-cut thing to do, because we know that their risk is going to start going up the second you stop it.
Just to stir the pot, I would share a humble difference of perspective. For people with isolated provoked venous thrombosis, I think the data that I humbly shared, pooled analysis from multiple studies, the point estimates are 3%, and bleeding is not minuscule. So that I would not say take everyone off, but I don't think we have enough data to support, considering that anticoagulation comes at a cost as well.
Am I going next, or?
Go ahead. Before beauty.
You sure about that? Okay, so it's a right heart symposium, right? So I wanted to ask something that I don't think that we talk a lot about, but I scratch my head often. Whether you call it chronic thromboembolic disease without pulmonary hypertension or chronic thromboembolic pulmonary disease. I have a mother and daughter, just two of my cases, that have profound differences in their symptomology, but without pulmonary hypertension. And I'm struck by sort of the lack of, at least from what I see, guidance or guidelines on how to take care of these patients long-term, both from an acute and risk stratification perspective. So I was wondering, as is relevant to each of your talks, if you could talk about what do we know about anticoagulation in this CTED patient population? What should we be thinking about provoking risk stratification in terms of the right heart? And I'm beginning to see people wanting to do balloon pulmonary angioplasties on patients who have minimal or some symptoms without extreme RV dysfunction. So I wonder if you can take that.
Yeah, that's a great question. I think those patients are definitely more challenging, right? If you have overt CTEF, it's pretty clear that something needs to be done. I definitely rely a lot on invasive CPET in those patients to sort of better understand their physiology and the reason why they're short of breath, and make sure, it's not really that their wedge is going up with exercise and they have HFpEF, and then a balloon procedure is not really going to help that problem. But there definitely is some data that if in patients with CTED, patients can have, PQ mismatch, dead space, and even exercise-induced pulmonary hypertension. And, those patients we treat the same as our CTEF patients. We will do PTE if it's surgically accessible, or balloon pulmonary angioplasty for more distal disease, as long as we are convinced that that is the cause for the symptoms.
I think that chronic PE population, even if it's truly CTEF, there's such little data for what we do with anticoagulation. I mean, I even wonder, to take a more extreme example, right? Someone who has very clear CTEF, but it occurred after a very provoked event. We typically leave those patients, they have their surgery, they're doing great, their initial PE was completely provoked. Like, do we really need to be leaving all of those patients on high-dose Coumadin? Typically, we're targeting an INR oftentimes a 2.5 to 3.5. When their initial event, they've never had a recurrence. It just really was an initial clot that never resolved. I don't know, and I think it gets even harder when you look at the chronic PEs that we find that maybe have a little bit of increased dead space or a little bit of exercise-induced pulmonary vascular dysfunction. It feels there's such little data on what to do. I don't know the answer to that.
And especially with what to do with anticoagulation.
Yeah.
There's no data. I tend to leave them on because I'm worried that if they have other events, then we'll be in a worse situation. But I'm not sure there's any data for that.
That's the problem that I have. The daughter who had a provoked PE with basically a chronic right lower lobe component to it, decided she didn't want to be on anticoagulation long term. So I worry about her every year. Mother has decided to stay on anticoagulation. And so, I think just to say that even the BPA or PTE, there is such lack of data in this group of patients that we need to be thinking proactively away from expert opinion. My cases are I do this kind of thing, and study the population prospectively in an organized fashion.
Absolutely. I hear some collaboration requests.
Good job. So actually I have one question and one sort of crazy idea. What a surprise. So as long as we're on clot burden, just as an idea, what about clot burden and the hemodynamics that then occur when you have chronic clot? Okay, that was not mentioned, i.e., is the clot burden important in the development of, obviously you get CTEF, so what does the clot burden actually mean in relation to the hemodynamics you get with CTEF? So that's one. And the second one, which is the sort of crazy idea, is let's say you have CTEF and your whatever risk is gone, you get a PTE or you get BPA'd, okay? Your numbers become completely normal again. You become a completely normal human being, and your echo goes back to normal. Why do you still need to be anticoagulated?
Yeah, I'll take the second one. That was the point I was making. I think we do this reflexively because of expert opinion.
But there are no data to tell me that.
I agree. I think as a PH physician, I'm much more afraid of clotting than bleeding. If I were a GI doctor, I would probably be saying the exact opposite. And I agree. I mean, the anticoagulation data for post-PTE, there's some studies that have come out showing that vitamin K antagonists are superior to DOACs, but they're all retrospective, and I would love to see like a more prospective randomization of anticoagulation.
In a way, it's back to the day when sort of obligatory after PTE, everybody got a filter put in until people said, this is stupid, okay? And gee, with not putting filters in didn't change anything. So I'm not sure that we need to anticoagulate people after they've been, quote, fixed after a chronic clot and it's gone away, which is just something to think about.
Yeah. About your first question, I'm not sure I quite know how to answer that, but what I would say is...
That's why I asked it.
My thoughts are that probably where clot burden matters is if you have a lot of proximal clot, like you can get severe pulmonary hypertension with proximal clot or distal clot, right? But you probably will have more benefit from a PTE if the clot is more proximal and surgically accessible.
Well, I think the issue I was trying to get to, I think, was this idea that you have these people who seemingly have very small clot burdens, okay, especially if it's distal, and have just insane hemodynamics.
Yeah.
And it's always been said, well, it just must be vasoreactivity or something. And why?
Well, a lot of it is that we're not seeing the actual clot burden once it's become chronic. We're not seeing it as well on our CTs, and maybe you can comment on that. The other thing is, a lot of these patients do develop small vessel vasculopathy that's, not related to clotting. And so that's the challenge in this disease and in distal CTEPH is how much is actual clot that we can fix with balloons and how much is remodeling of the vasculature and now more of a PAH type picture.
Well, and I think the third aspect of that is the fact that you can have incredible, you can have a very small clot burden and have areas where the pulmonary pressures are incredibly high, even though there's never been a clot there.
Right. Well, I don't think we have a great way to measure clot
But those were
burden in
probably distal
vessels.
clots that we just didn't pick up.
No, I mean, I think, jumping in this, I think that, to me, the clot burden, I think of it, the tool of clot burden on CT was really, I think, developed in a way to look for PE. The problem is once you're even talking about chronic, I mean, the surgeons will tell you, like, you don't see anything, but then when we open the patient up, we take out, like, so our ability to visually quantify particularly chronic thrombus burden once it's reorganized is not that good. I think it is in the sense that if you have a tiny clot in your right lower lobe, that person is probably much better off than someone who has a lot of clot. Probably. But once you are talking about really people who are sick, then that fails to be of relevance, which is why I think that we need ways of assessing the vasculature differently than by just looking for central clot.
And it's also why we still use pulmonary angiography to get that kind of additional detail, because CT is so amazing and so precise, but it's still not good enough for CTEPH.
So a little different question as I knock everything over here. A clinical problem I've run into is how to assess efficacy of a catheter-based intervention while it's going on. You get to the point where you get more aggressive and risk-benefit begins to shift, but you're looking at a real-time response, whether it's catheter-based thrombolysis with, ultrasound, maceration, suction. So how do you recommend tracking efficacy during the intervention to tell them to say it's time to stop or the risk-benefit is beginning to shift? And I'm not quite sure how to do that, because you can't really do a CT or any of the other interventions while that is going on.
Yeah, it's a tremendous question, and it's one of the big challenges with catheter-based intervention for pulmonary embolism. We don't really know what metric is that tells you can stop. It appears that proximal angiographic obstruction, what you could see on intra-procedural pulmonary angiography doesn't really tell you when you're done. In some of those patients, they'll have mechanical embolectomy until they've gotten everything that they can reach, but are you really done? In other patients, they'll get mechanical embolectomy, and then they'll put in infusion catheters overnight. There's not a good measure thus far. It may be that if we get a way to assess perfusion and distal sort of increase in blood volume, that may be helpful. There are data that Nick worked on that showed that after some of these procedures, the patients that get right ventricular recovery actually are the ones that get distal reperfusion, where you have pruning and distal cutoffs, and then after the procedure you get reconstitution of the more peripheral cross-sectional area vessels. That is the only study of which I'm aware, it's Seattle 3D, that actually looked at whether improving distal perfusion correlated with recovery of right ventricle. It may be that if you had a catheter that could measure pulmonary artery pressures in the particular pulmonary artery, or measure gradients like you might do with an FFR in the coronary system, maybe that will be helpful. But currently we don't have a metric for that. And so it's left up to the operator, and it's the Wild West out there. Patients are getting hybrid procedures with, 2 hours on the table with FlowTriever, and then they go up to the ICU with ECOS catheters.
Yes.
We don't. I wish I had a good answer for you.
I understand that, and you hit the nail on the head with the situations we've encountered. The thought kind of is, though, if the endpoint is RV function, if your endpoint is improvement of RV function, is there any benefit to a methodology then that tracks recovery of RV function during the intervention? I don't know if that's an answer, but it's kind of an interesting concept.
Yeah, no, I mean, a surrogate for RV, the only surrogate for RV recovery that I've seen that has good data would be sort of these measures of distal perfusion, and that's hard to get on table.
Yep, all right, thank you.
Okay, so as one of the operators who does the procedures, a couple of comments and then a question on something completely different. So I just want to push back on the idea that FlowTriever leads to a massive drop in crit, because the system has been redesigned and there is a cell saver. So all the blood pulls, every pull pulls 50 mLs of blood. All of that goes back to the patient. So that is all right. So the crit drops of the early days are not happening.
Unfortunately, the data show that FlowSaver device is only deployed 30% of FlowTriever procedures nationwide.
Nationwide, I can tell you that in our institutions, on both sides, we are 100%.
You should also look at the real PE study that was presented that demonstrates that in the hands of the everyday operator across the U.S., and granted, there's a lot of limitations to looking at real-world evidence, but for whatever it's worth, really substantial drops in hemoglobin need for transfusions after FlowTriever.
Again, we are some of the early centers who are using this, being trained using it, and then this will disseminate, all right? So I would just say early experience with best practice, that crit drop has been alleviated. So that's the first thing. The second is there is forthcoming RCT data from the Peerless trial, which we're enrolling in, which is FlowTriever versus catheter-based thrombolysis, which will look at clinical outcomes multi-center. So I agree with you, there is no data in how we are practicing, but it is forthcoming. It's not like we completely forgot about this. And then in terms of doing the procedure and when are we done, you're right. There's a lot of variability. However, when we do these procedures, we do pulmonary angiograms to look at distal perfusion, and a lot of that has to do if the clot is accessible with the catheters and the new catheters that are actually shaped to get into the left pulmonary circulation, which was always the harder one to get to. With those, we go until we can't get any more clot with the catheters, and we have achieved perfusion. If we have not achieved full perfusion, that's when you're going to see the hybrid procedure.
And so I would say that that's fantastic. Two comments to that. One is, to really push the field forward, we need things that can be used by every person, every operator, not just the Brighams, the MGHs, and because we have to worry about, there are signs that mortality is going up in high and intermediate high-risk PE in the U.S., and so to really push that into our communities, we need something that people can use. And these innovations to FlowTriever sound fantastic, being able to have a more steerable tool to get more, but that makes it more technically demanding. And
it actually makes it technically easier.
Well, let's see how that pans out. It might be technically easier at Brigham, but in the community, the data suggests that, these devices are a little bit more technically demanding and results aren't as good as you see in a flash or a flame registry. And we just have to be mindful that what we accomplish at the Brigham may not be what's readily accomplishable throughout the U.S. and outside the U.S.
Yeah, this is true for any cath lab-based procedure. It takes time to disseminate.
Right.
My question has absolutely nothing to do with this. So, no, my question is, given how bad, as Aaron said, how bad we are at anticoagulation, when do you start assessing people to see whether or not they have CTED? Do you wait for symptoms? Do you have a certain time frame for when you start doing imaging? And if that's the case, what do you do and what kind of tests should we be looking at?
I will share some basic humble thoughts and then love to hear how the practice might be different by other colleagues. To me, the first question when I want to order any test for my patients is, how is it going to inform me to help my patient better? And we are talking about PE per se, which has been there for decades, and we're debating multiple procedures after years of use with 510K clearance, really no approval for any of these devices. We're just getting data over the next 2 years from multiple trials. Going back to your question, to the extent that I know there are 0 large-scale trials ongoing for CTED, so the question that I have for my patient is, if I get some information, what do I really do with it? And we can experiment a lot of things. Some patients are in very difficult situations, and those few I might. But in the absence of trial data to inform my patients, I would actually not get them routinely. Defer to the rest of the team to see what they think.
I think, all the studies have shown that the incidence of CTEF and any CTED even lower than CTEF is still quite low. So I think, doing repeat imaging on everyone is probably not worth it. Like I said, our algorithm is if the RV looked abnormal, we are 100% going to repeat an echo. And if that echo is still abnormal at the 3-month mark, we are going to go get a VQ and down the route of that algorithm of CTEF diagnosis. If the RV recovered and the patient is asymptomatic, I'm not going to do imaging.
Okay. All right.
Yeah, I mean, it brings up the challenge of the patient who presents acutely with what you think is CTEF as well, and how to figure that out. I think doing this is humbling. I've had a couple patients I can think of where typically we say you should wait 3 months of anticoagulation, where I am convinced this is all going to be chronic, but they're stable. They can wait 3 months to see what happens of anticoagulation. And a lot of times I'm right, but there's definitely times where I'm wrong and it goes away. So I think ideally you're waiting 3 months before making that assessment.
Okay, great.
I was just going to follow up to Hap's question about why do we continue anticoagulation after doing a PTE or whatever. Doesn't it come down to the fact that we have no idea who's going to get CTEF or CTED or why they get it? And has to be an inherent abnormality of fibrinolysis to even get there, so that inherent abnormality doesn't go away, especially since we don't know what it is?
Right, but I guess the point, and I don't know the answer to this question, but we think it's a problem with fibrinolysis, but if they had a provoked event, and you treated it, what?
That Cam just did, the kid, like 27 years old, got clots from flying to Australia, back and forth, because his wife was from Australia.
It's the wife's fault.
That's the best solution. But no, it's, I think some of those people, you might be right, but some of them, they just had, for some factor, that led to chronic clots that we don't know, but in a lot of these people, you could argue that in a lot of these people who have clots, we have no idea why they had the clot in the first place. So everybody should be anticoagulated.
Well, a lot of them are unprovoked or have some obvious thing like APLS, and those patients anyway, the guidelines suggest long-term anticoagulation is beneficial. So I think we're talking about a small percentage of patients who maybe had knee surgery and developed a clot and then had CTEPH. In those patients, I think it's less, I understand less. Do we actually, do they have a clotting problem, or it's just that if they get a clot, they can't dissolve it? And so now that we've removed their clot and their risk factor, do we really need to anticoagulate them? And I think that's the question we don't know.
To make it more complicated, Aaron knows this, and this audience probably knows this more, better than any of us, that the pathophysiology of CTEPH is very poorly understood. And we have patients that come in, have pulmonary hypertension, have minimal, thromboembolic disease, small webs, and systemic pulmonary arterial pressures, and they can't remember having a PE. They can't tell you, I never had a PE. So we don't really know if we're talking about a really heterogeneous disease or even multiple different diseases. Some patients who might have PH and then develop PEs because of the PH, and other patients that develop PEs and then for some reason as a complication of that develop PH. And so the question is, what's the underlying defect, and is anticoagulation modifying that? If it's a patient that has had a bunch of PEs and you do a thromboendarterectomy and they're completely recovered, do you know that you fixed the underlying issue of why they're having PEs? And so we don't know the answer to that. So I think in the absence, there's the saying, in the absence of light, shadow prevails. That's where we are.
I think once you open somebody's chest, though, my threshold for taking a risk is higher, right? I will err on the side of let's prevent this from happening again.
I would just quickly comment. I agree. For our bread and butter patient, what is the risk if we stop another recurrent, say like if it's a distal DVT, recurrent distal DVT? If somebody was so sick that required CTEPH surgery, you are subjecting the patient to that risk and potentially redo operation if ever a candidate.
This is a great discussion. First off, in terms of just a comment on CTED, before we have any interventional trials, we should phenotype exactly what CTED is, because we can't agree on a definition, would you say? My plug is for CPET.
Yeah.
At least in the context of imaging. Right?
I agree. I think in those patients, CPET is, you have to do it to understand what's happening.
Absolutely. But I'm going to take it back to the acute PE. Whether it's clot in transit or clot already in the PA, the threshold to make that decision of whatever your intervention is going to be in terms of thrombolysis, catheter, or PT, or surgical embolectomy. Obviously, that's a big step to take. And I don't feel like where we are in terms of trying to make that decision with PESI scores, with the typical, I think at least phase 2 trial endpoints of RV to LV ratio on CT is adequate really to tell us that. And to me, it comes down to obstructive shock. Who's going to die of obstructive shock, especially that group that comes in with submassive PE, another thing that's sort of poorly defined, right? but we didn't really touch on that necessarily. And so I want to hear from you all as to what you think the future is to move towards, with all these different interventions, what are we going to use? What modality are we going to use to define that trigger point?
Yeah, it's a great question. And I think that one of the challenges is the technology is advancing at a fantastic rate. And we're learning so much about PE from all of these different devices. The problem is we're applying them to an incredibly heterogeneous population. The intermediate risk PE population now is subdivided into intermediate low and intermediate high, with intermediate low typically not getting intervention, and intermediate high still representing an incredibly heterogeneous population, with some patients that will decompensate and others that will do fine on anticoagulation alone. That's why the ESC guidelines recommend monitoring those patients. What we desperately need in order to match the advances that we've seen in technology is a tool to identify which intermediate high-risk patients are more likely to go on to decline and need intervention. Then we can start to ask the question of, okay, which device is best for this anatomical distribution of PE or this clinical presentation? But before we do that, we need to know which of these patients should we be preparing for a procedure or fibrinolysis. There's some work that's looking at different echo parameters. There's other work looking at terms of pre-shock, looking at composites of lactate, looking at the changes in MAP, looking at time-dependent variables and time-independent variables. One of the things that could be helpful is in Europe, they're quite a fan of the NEWS score, which is a way of sort of looking at a set of different time-dependent variables and determining it does change in the NEWS score tell you before a patient becomes hypotensive that they might be deteriorating. We don't really know. But I would say that where the research is really needed is in parsing out the heterogeneity of intermediate high-risk PE. Then we can answer your question.
Yeah, I would just even add I'm not even sure, I think we all would agree that doing a procedure for somebody who we can predict is very likely to decompensate, I think we're all going to agree on, but I'm not even sure, is decompensation the right outcome that we're trying to avoid? I mean, there's some data that in the right hands, these interventions, particularly catheter-directed thrombectomy, can avoid an ICU stay, can limit the time someone's in the hospital, can get them feeling better quicker and back to work. And I don't know what the field's going to look like in the future. My suspicion is as more and more people get comfortable with these devices and the complication rate goes down, that we're going to see actually probably more catheter-based thrombectomy, not so much to prevent people from dying and to prevent people from getting critically ill, but to get people out of the hospital sooner, out of the ICUs, and back to work and their normal quality of life.
I think we are very primitive in our current risk stratification paradigms. We're just using a handful of risk factors really similar to how we were doing in 1970s. Phenotyping is far behind where it should be. And maybe one success story, if I may, to contrast it as a cardiologist, is how TAVR procedures came out. If you look at the Society of Thoracic Surgery joint statements and the way they developed their models, there is no single one way to get to the outcome of choosing for SAVR versus TAVR. But in a community where we have a lot of pulmonologists, imagine what we should do when you see respiratory failure and hypoxemia, to my knowledge, is not in ESC, AHA, ACCP, or any other guideline. So if somebody is in respiratory failure but not hypotensive, technically you cannot call that high-risk PE, even though all of us think otherwise. So the point that I'm trying to make is I think we have to get smarter and better with risk stratification. And as Dr. Leopold was mentioning, we have several trials ongoing. Maybe 2 to 3 years from now, we have to change our paradigm from our reductionist approach to a more sophisticated way of phenotyping these people.
It is not my pleasure to end this very, very enlivened discussion, which has been great. But I think it is
I think you have one audience member who's taking
Oh my
exception to
God.
that.
You're tired of, there's something in the Boston water that's making me ask all these questions, but you want me to stop? I want to ask my question. Do you want me to ask my question? Go for it. Okay, I'll be really quick. I'll be really quick. So PE is not a rare disease, right? But we're expert centers that we're developing a lot of experience. There's anecdotal comments that I've heard people tell me that radiologists always misread VQ scans and CT scans. And I never really believed it until a couple of weeks ago, saw a CTEF case in the ICU who had a CT scan a year prior, and even I could see the PE. So the question I have for you guys is, what is being done in the community about improving the reading of CTPE studies, and what do we know about inaccuracies or accuracies that exist? I mean, these are trained radiologists in modern days, so I'm surprised that these are being misread. But I wonder if there's any literature or any initiatives being done to work in the community.
Yeah, I mean, I think that training radiologists continues to be challenging because expertise in VQ decreases. Expertise in CT is a little better, but sort of radiologists are training broadly, especially in the community, and aren't just thoracic CT imagers. So where we're going to end up probably relying is on AI-guided diagnosis of pulmonary embolism. There are a couple of smaller studies that have shown the accuracy of AI diagnosis of filling defects on a CT is actually quite good. And it may be that some sort of a hybrid approach merging a human reader and AI may be where the comfort zone in the community is. Behnood also is looking at some other techniques for helping identify patients using EHR-based methods. It may not be in the moment in the ED, but months down the line, is there a way to flag patients who had PE and have someone else? The problem is clinicians working on two different things at the same time. A hematologist is working on treating the patient's PE, and a pulmonologist is noticing pulmonary hypertension. We've got to put those two together in order to arrive at the diagnosis at CTEF. Behnood.
No, I think that's excellent. The only other thing that I would share to end my thoughts on this session, subsegmental PE is the most notorious in my humble opinion. There are some studies for more centrally located clot, there is less heterogeneity, but even among trained radiologists that you're specifically asking them, is there a PE or no, up to 30% of them do not agree for subsegmental.
And BQ is a lost cause with radiologists.
Unfortunately.
I just look at them myself.
Yeah.
Thank you, everyone.